The Dix-Hallpike test revisited. Were Dix and Hallpike wrong? This video is by me, Peter Johns, an emergency physician practicing in Ottawa, Canada. If you're interested in the history of medicine or in vertigo, you just might find this video worth watching. Some authors have suggested that Dix and Hallpike made errors or were wrong when they described that there was generally a horizontal component to the nystagmus seen in BPPV. Other authors skirt this issue by omitting this part of Dix and Hallpike's description. So were Dix and Hallpike wrong? Spoiler alert, I don't think so. In fact, by examining their data from the original Dix and Hallpike paper, I'll give evidence to support my theory that they made an accurate description of the nystagmus seen in regular BPPV, that is posterior canal BPPV, as well as geotropic and apogeotropic horizontal canal BPPV. And through this fresh look at old data, we just might get an idea of why many clinicians today don't like vertigo and have been reluctant to adopt one of the most effective treatments in medicine, the Epley maneuver. First thing I'll do is introduce you to a very interesting paper by Lanska from 1997, where he talks about the origins of the positional testing and conceptual developments. Really great paper. And one of the first things he talks about is how Robert Barani in 1921 described one patient with BPPV. And he did a very good job of describing what he saw, which was, you can see a strong rotary nystagmus to the right, which was the downward ear. And he also described a vertical component upwards. Now, some of you are thinking, vertical nystagmus, that's bad. Well, it is bad if you see it spontaneously, as in this gentleman who is not undergoing a Dix-Hallpike test, but merely being asked to look upwards. You do see upward vertical nystagmus, and in fact he had MS, and that's not a good thing. But in this lady undergoing a Dix-Hallpike test testing her left ear, the downward ear, you see a little latency where nothing happens, and she gets a crescendo-decrescendo nystagmus, which is clearly has a vertical component, as well as a rotary component towards a downward ear. I'll show that in slow motion in a second. It lasts around 12 seconds or so. So initially, you start to see some rotation of her iris. She has a very nice light iris, so you can see the rotation towards her downward ear. And then pretty soon you start to see vertical upward movement of the pupil, which means she has vertical upward nystagmus with and also a rotary component towards the downward ear, a classically positive Dix-Hallpike test, and she has BPPV, and she had it and she was cured of it. This is what Barani described in 1921. This diagram shows what happens during the Dix-Hallpike test or whenever the patient rolls over in bed or lies down in bed. In this case, it's the right posterior canal being stimulated by otoconia or otoliths or ear rocks or whatever you want to call them, and both eyes develop the characteristic rotatory and vertical upward nystagmus. And this is because the right posterior canal sends impulses through the nervous system to stimulate the right eye superior oblique muscle. And of course, the left eye moves in a reciprocal way to maintain conjugate gaze. Looking down at the eye from above, this illustration shows how the superior oblique muscle loops through a pulley-like structure called the trochlea before inserting into the posterolateral aspect of the globe. Just imagine that my hand is representing my right eyeball, which I'm looking down on, and my finger is pointing the direction of gaze. Now, using this rather elaborate elastic and duct tape model, I'll show you how the superior oblique acts during the Dix-Hallpike test. So here you can see how the superior oblique creates the vertical upward nystagmus with a rotary component towards the downward ear. Some of my emergency medicine colleagues are somewhat disbelieving that there's actually vertical nystagmus seen during the Dix-Hallpike test. So just to show you I'm not the only one who thinks so, here are some review articles that describe it just that way. In this excellent 1999 review article in the New England Journal of Medicine, Furman describes the nystagmus as beating vertically upwards towards the forehead and rotational component towards the downward ear. 15 years later, in yet another review article in the New England Journal of Medicine, Kim and Z describe the nystagmus as being upbeat and torsional towards the downward ear. They, for some reason, dropped the term vertical in their description, which I think creates problems that I'll discuss in a moment. Even worse, in their table 2 in this article, they described the nystagmus as being upbeat and ipsiversive torsional. Perhaps not surprising that two neurologists who specialize in research in vertigo would use some fancy jargon, but a bit disappointing that they would use this term in a review article whose target was clearly not the vertigo experts, but the vertigo naive who were trying to become vertigo competent. And finally, in this comprehensive and excellent clinical practice review, which was updated in 2017 by Bhattacharya and many others, he described the vertigo as being upbeat torsional. Again, avoiding the word vertical for some reason, which I show you in a second, is a problem. Another interesting observation that Bharani made in his original paper was that when the patient that he saw directed their gaze towards their downward ear, the nystagmus became purely rotational, and when they directed their gaze towards their upward ear, the nystagmus became purely vertical. So when they're looking straight ahead, it's vertical upward and rotational, and when they direct their gaze towards their downward ear, it becomes almost completely rotational because that's the way the superior oblique is pulling, and when they direct their gaze towards their upward ear, it becomes almost purely vertical because, again, superior oblique pulls that way. Now, why have I not seen this before? And could I reproduce it in a patient? Turns out I can. So in this left ear Dix-Hallpike test, when he looks towards his downward ear, it's more rotational, and when he directs his gaze towards his upward ear, it becomes more vertical. And another example, this time of the right ear, where when he directs his gaze towards the upward ear, it becomes more vertical, and towards his downward ear, more rotational. Now, why am I so concerned about the fact that the nystagmus seen in a positive Dix-Hallpike test is often not described using the word vertical? Well, the reason lies in the fact that almost everyone who learns about vertigo the first time, the thing they grab onto is that vertical nystagmus is bad, that it's central. So if you see any vertical nystagmus, you've got to, rule out a central cause. When in fact, the most common nystagmus you'll see in almost any clinical scenario will be the positive Dix-Hallpike, which often will have a vertical component, especially if you have them look towards their upward ear. Kerber in this study showed emergency physicians a positive Dix-Hallpike with vertical nystagmus, and these are some selected responses he got. And these people did not believe that it was a positive Dix-Hallpike. They thought it was a central cause. It might be PCP. Obviously, these kinds of attitudes would not lead to appropriate treatment with the epi maneuver and probably lead to inappropriate imaging and overall a poor assessment and treatment of BPPV. Finally, we get to the original paper by Dix and Hallpike, where they describe the test for BPPV, which bears their name, and also what they observed when they performed it. But first, they give Bharani's description of the nystagmus he saw in his one patient with BPPV in 1921. Here's what Dix and Hallpike quoted Bharani as writing. And you'll notice that the vertical aspect of the nystagmus is not included. Just to refresh your memory, here's the original quote I showed you at the beginning of this video. Here's a quote from the Lanska paper. He found this curious and felt that they must have intentionally left this out, which of course they did. They then went on to describe what they observed during their positional test, which became known as the Dix-Hallpike test. And what they observed was the nystagmus was chiefly rotatory, directed towards the downward ear. That is the same as what Bharani saw and the same as what we just saw in our videos. But if you look at the highlighted part, they also said that there's generally a horizontal component, which is again directed towards the downward ear. Now, we didn't see that in the videos. That's not what Bharani saw. So why did they say that? In the first article I showed you by Lanska, he described this as being the sole error of their clinical description. That, in fact, the nystagmus is not having a horizontal component, but does have that vertical or upbeat component, especially when they look towards their upward ear. Robert Balow, legendary vertigo clinician, researcher, and historian, in his book about the history of vertigo, also addressed the fact that Robert Barani, in his one case, described the nystagmus scene as being rotatory with a vertical component upwards, while Dix and Hallpike described in their series of 100 cases that they saw a rotatory nystagmus with generally a horizontal component towards a downward ear. Balow's conclusion was that Barani was right and Dix and Hallpike were wrong. In her book, Carol Foster, of the half somersault maneuver fame, wrote a 25-page chapter covering the history of the discovery of BPPV, including 6 pages on Barani. And oddly, she chose to include the Dix and Hallpike's misquote, seen above, rather than Barani's original description, seen below, despite listing Lanska's paper as a reference in her book. And a few pages later, when describing the nystagmus scene in Dix and Hallpike's original paper, she is incomplete in her description and only says that Dix and Hallpike observed the eyes appeared to be beating towards the floor, and not whether they did so in a rotatory or horizontal fashion. And she certainly didn't mention the vertical nystagmus, which, as I showed you, is often seen during the Dix-Hallpike test. So what the heck is going on here? Were Dix and Hallpike wrong? Why didn't they describe the vertical nystagmus that Barani saw? And why did they say they saw horizontal nystagmus? The first thing I'll discuss is why they didn't see or describe vertical nystagmus during their Dix-Hallpike test. The answer may lie in this paper published 4 years later by Cawthorne and Dix and Hallpike, where they include a small diagram of how to perform the Dix-Hallpike test. So in the text below the diagram, you can see that they suggest that the patient looks at the examiner's forehead, and you can see the examiner is on the side being tested, in this case the right side, and that once the patient is in the Dix-Hallpike position, you can see the little pupils on the enlarged diagram of the head, that they are looking towards the downward ear because that's where the examiner's forehead is. And that might produce a Dix-Hallpike test such as this, where you pretty much see only rotatory nystagmus towards the right ear, and you don't see any vertical or horizontal nystagmus. And many people still do it that way, as in the upper illustration, but I find that to be kind of hard on the back. You notice this person who's doing the Dix-Hallpike test, it looks kind of awkward and uncomfortable. I prefer to do it as it's illustrated in the bottom illustration, where clearly the examiner is behind the patient, possibly seated, and I think this leads to a much more easy and comfortable Dix-Hallpike test. This is how I perform a Dix-Hallpike test. You'll see that the volunteer has been turned around, so his head is now extended over the foot of the bed. I'm sitting on a stool, so my back is straight. I'm able to fully support his head, so he is comfortable. My forearm is resting on my knee, so I'm comfortable. And you'll notice that my head is more or less towards his upward ear. And since the patients generally sort of end up looking at you during the test, I more often see vertical nystagmus than the purely rotatory nystagmus that you might see in the other technique. So I think the reason why they didn't see or describe vertical nystagmus was because the way they performed their Dix-Hallpike test did not produce vertical nystagmus, only rotational. Now the second question is, why did they say they saw horizontal nystagmus? A clue may be in Lanska's paper, where he said that you don't see horizontal nystagmus in positional vertigo except in rare cases of horizontal canal BPPV. Horizontal canal BPPV was only described more than 30 years after the Dix-Hallpike paper in 1985 by McClure from London, Ontario, plug for Canadian content. Now, can horizontal canal produce horizontal nystagmus during a Dix-Hallpike test? Sure it can. This guy, we thought, had regular BPPV, but when we did the Dix-Hallpike test testing his left ear, downward ear, we saw purely horizontal nystagmus towards his downward ear. Now, when we tested his right ear with the supine roll test, we also saw purely horizontal nystagmus, this time beating towards the right ear, which is again the downward ear. This is called geotropic horizontal canal BPPV, and both sides produce nystagmus, which beats horizontally towards the downward ear. For more information on how to diagnose and treat horizontal canal BPPV, click on the link on your screen. For horizontal canal BPPV, generally one side has more intense nystagmus, and the direction of the nystagmus on that more intense side points towards the affected ear. So this man has right ear horizontal canal BPPV and not bilateral posterior canal BPPV. Since patients with horizontal canal BPPV present with a history very similar to posterior canal BPPV, it isn't hard to imagine that if Dix and Hallpike saw this patient, they would conclude that he was suffering from bilateral BPPV. There's also another variety of horizontal canal BPPV called apogeotropic horizontal canal BPPV, where the nystagmus beats away from the downward ear on both sides. In this man, his Dix-Hallpike test testing his right ear produced apogeotropic horizontal nystagmus beating away from the ground and towards his upper ear. As is common with apogeotropic horizontal canal BPPV, the nystagmus was quite persistent. When we tested his Dix-Hallpike test with the left ear down, he again got apogeotropic horizontal nystagmus, in other words, beating away from his left ear towards his right ear, and it was less intense on this side, indicating that the affected ear was in fact the left ear. Now again, in Dix and Hallpike's original paper, they described 38 cases of bilateral BPPV. Could it be that the bilateral BPPV they saw was actually horizontal canal BPPV, and they saw a lot of horizontal nystagmus, and that's why they described it as part of the component of a positive Dix-Hallpike test? But if Lanska is correct and horizontal canal BPPV is rare, that doesn't make sense. But is horizontal canal BPPV that rare? A number of recent studies would suggest it's very common. Vanni's study, which looked at undifferentiated vertigo patients presenting to an emergency department in Italy, he taught emergency physicians how to diagnose posterior and horizontal canal BPPV as well as other bedside vertigo tests. Half the patients that he saw, of the 352 patients he saw, did have BPPV, and of the BPPV patients, 39% had horizontal canal BPPV. Another Italian study looking at almost 2,700 patients presenting to vertigo clinics in Italy showed that 38% of the patients with BPPV had horizontal canal BPPV. Just so you don't think it's only Italian adults who get horizontal canal BPPV, this American study showed that in 110 pediatric patients with BPPV, 34% of them had horizontal canal BPPV. And from Korea, 1,900 patients, 31% horizontal canal BPPV, only 14% bilateral. So how does this make sense? The Korean study, which had 19 times as many patients as the Dix-Hallpike study, showed 14% bilateral BPPV, but 31% horizontal canal BPPV. Of course, they were all diagnosed by seeing horizontal nystagmus, while the Dix-Hallpike study showed 38% bilateral and 0 cases of horizontal canal, and yet they described generally a horizontal component to the nystagmus. In this hot-off-the-press study by Pollock of 2,000 patients with BPPV, less than 3% had bilateral posterior canal BPPV, and she correctly notes that it's possible to misdiagnose horizontal canal BPPV as bilateral posterior canal BPPV. And of course, this would be an even easier mistake to make 30 years before the first report of horizontal canal BPPV. One last study, this one also from Korea, where they had 62% posterior canal, 35% horizontal canal, of which about 2/3 were geotropic, where the nystagmus beats towards the ground, and about 1/3 was apogeotropic, where it beats away from the ground. That's a fairly typical ratio of geotropic to apogeotropic horizontal canal BPPV. So, given that, did Dix and Hallpike see apogeotropic horizontal canal BPPV? In fact, they did describe 3 out of their 100 cases where the nystagmus seen was beating towards the uppermost ear. In other words, away from the ground. That doesn't occur in posterior canal BPPV, but that is exactly what happens in apogeotropic horizontal canal BPPV. So the answer to why they said there was generally a horizontal component to the nystagmus seen, and why more than a third of their cases were described as being bilateral, is that they were describing the common features of geotropic and apogeotropic horizontal canal BPPV. Interestingly, Balo in this paper describes how in 1977, towards the end of his life, Hallpike at a Barani Society meeting argued that the characteristics of the nystagmus indicated that it must arise from activation of several canals rather than a single canal. So there are 4 facts from the Dix-Hallpike paper that need an explanation. Firstly, they don't describe the vertical nature of posterior canal BPPV. Secondly, they describe 38% of their patients having bilateral BPPV. And thirdly, they described a generally horizontal nystagmus seen. And lastly, they describe some cases of nystagmus beating towards the upward ear. There are 2 possibilities. First possibility is that they saw vertical nystagmus but chose not to describe it, that all their patients had posterior canal BPPV and 38% of them had bilateral BPPV, and that they never saw horizontal nystagmus but they erroneously described it anyway, and also that they never saw nystagmus beating towards the upward ear but they described it anyway. Now I've already explained why the way they performed the Dix-Hallpike test is why they never saw vertical nystagmus and so they never reported it. Possibility 2 is my personal theory of why they wrote what they did in their paper. And we already went through item number 1, items 2, 3, and 4 are all explained by my theory that they were seeing a significant portion of horizontal canal BPPV, which would explain why they reported so many bilateral cases, why they saw a lot of horizontal nystagmus, and why they even saw cases where the nystagmus was beating towards the upward ear. If we use Occam's razor, which can be paraphrased as the theory that makes the least number of assumptions is the most likely to be true, then I think my theory is probably true. So just to summarize, my theory is that Barani had the nystagmus correctly described for his one patient who had posterior canal BPPV, and he described rotatory and vertical upwards nystagmus. While Dix and Hallpike, in their 100 cases, described the 2 predominant types of nystagmus seen in BPPV, which is rotatory in posterior canal and horizontal in horizontal canal BPPV. But they didn't distinguish them from being 2 variants of BPPV, and that's because horizontal canal wasn't described until almost 33 years later. So why should we care? Well, I think it's important to recognize that their observations weren't wrong or in error, that we can now safely remove this small stain from their otherwise spotless reputation. This only adds more validity to their hallmark study because now we know that they were describing the features of posterior canal as well as both geotropic and apogeotropic horizontal canal BPPV, albeit without a full understanding of what they were observing. Now, what does this have to do with the poor adoption of the Epley maneuver by emergency physicians, primary care physicians, and others? Well, despite the fact that the Epley maneuver was described over 25 years ago and that it works on the most common form of BPPV, which is the most common cause of vertigo, and that it has one of the lowest number needed to treat in all of medicine, and that it's safe, easy to perform in minutes, you don't need fancy equipment, and the fact that emergency physicians state that they like doing procedures, it's rarely done by emergency physicians. Now, what are the consequences when you don't recognize that vertical nystagmus is normally seen in posterior canal BPPV? It might lead you to not attempt the Epley maneuver, which is a highly effective treatment. It might lead you to over-investigate with CTs or MRIs or over-refer. And frankly, there's not enough dizzy experts in the world to treat all cases of BPPV. Primary care physicians, emergency physicians have to step up and learn how to diagnose and treat BPPV. So what's the consequences when you don't recognize that horizontal nystagmus seen during the Dix-Hallpike test is likely horizontal canal BPPV? If you mistake this for posterior canal BPPV, you might attempt the Epley maneuver, which doesn't work for it. And if you're starting to do the Epley maneuver on everybody has BPPV and a third of your cases are horizontal canal BPPV, you've now decreased the effectiveness from 80% of the Epley maneuver to less than 50%. And let's face it, a procedure that is effective in less than 50% is not a procedure I'm very interested in doing. You're going to stop doing it, you're going to say it doesn't work, and that's going to lead to over-investigation and over-referral again. So does all of this have any significance today? Yes, I think it does, because it's important that vertical nystagmus should regain its prominence in the description of a positive Dix-Hallpike. And it should be known that if you see horizontal nystagmus during a Dix-Hallpike test, this is probably horizontal canal BPPV. It is not uncommon, and it needs a different diagnostic test and a different cure. And if you can understand these facts, then you can cure more people of both posterior and horizontal canal BPPV and have improved the outcome for your patient and better satisfaction for yourself. I hope you've enjoyed this little historical deep dive into the history of the Dix-Hallpike test. If you need any video references on how to diagnose and cure either posterior canal or horizontal canal BPPV, the links are on your screen. Thanks for watching.